Welcome in. I'm Collette Wieland alongside Dr. Stephen Camarata. Steve is a professor, a best-selling author, a late talker himself. He is internationally recognized for child development work, especially focused on how children learn to talk. Today, we're going to talk about apraxia, intervention, treatments for it. Last week, in case you missed that discussion, go back, check it out, because we're going to elaborate on that. So if you want to learn more about what apraxia is, Steve's going to tell us real quickly, but you'll learn more from the previous episode. So starting off, what is childhood apraxia of speech?
So apraxia is a general term, and it's interesting. The basic idea is that someone can make a movement involuntarily, but when you ask them to do it on command, they can't do it. So it's a broad condition. It was first discovered over 100 years ago, or first described, I should say, over 100 years ago. And the basic idea, and it can apply to limbs as well as speech, hands, legs, and so on. So the idea is you might have a patient that's had a stroke. They're rubbing their head like this, and then you come in and you say, "Oh, Miss So-and-so, can you rub your head like this?" And instead of doing this, they can't do it. So you know they could do this. You have evidence that they can make the movement, but they can't do it on demand. So we think of it as a motor programming problem. Now, speech is one of the most complicated motor activities that we do. And so apraxia of speech is generally defined as the inability to make speech sounds when there's evidence that they can actually move their tongue and coordinate for the movements. That's the basic definition. Historically, it was only applied to adults. In the late 1960s through the 1980s, clinicians working with stroke patients noticed some of the same symptoms in children. And so then this kind of brought about this idea of childhood apraxia of speech. Unlike adults, though, we don't necessarily, in fact, we rarely see a stroke or some other event. It's actually something that happens. It's a very severe speech disorder. These children are really hard to understand, but we don't necessarily have a specific cause for it, a neurological cause or something like that.
What age do you typically see those signs and symptoms?
So certainly when a child hits 3, you can really tell if it's a severe speech disorder. Normally there's enough of a sound inventory or phoneme inventory, the speech sounds that kids make, you can tell if they can make them in some situations but not in others. But certainly by the time a child hits 5, you're really sure. Based on babbling characteristics and intonation patterns, you can actually tell a little younger. There are children I see that are toddlers, 2 years old, where I'm nervous about it because they have very few sounds and they have disruptions in their prosody. As an aside, I learned about if you're speaking Chinese, being able to do different tones is important. And so the Chinese have actually developed a phone app. So the child talks into the phone. If they can't do those intonation things in Chinese at a young age, they know they're at risk for speech disorder. And that may be something we can develop down the line for apraxia, because there are disruptions in intonation and stress for it as well. So anyway, certainly by the time a child's 5, we know for sure, and we're pretty confident by the time they're 3.
How do you start treatment with a child?
So this is an area of great controversy, and part of the challenge is that there's a debate about exactly what apraxia is and isn't. And we do know definitionally it's a motor planning problem, and again, it originally was secondary to stroke. We don't have that in children. But a lot of times people will identify apraxia of speech, and then they will try to basically either do movement activities that aren't even related to speech. They may do tongue exercises or things like this that aren't related to speech. They may put the child into a seat and have them try to imitate sounds. And if you think about it, because apraxia of speech is where they can make the sounds under less stressful, less forceful conditions, sitting down and prompting a child and forcing them to talk really is their worst modality. So it's always been of interest to me that people are really recommending this when, in fact, that seems like it might not be the best way to approach that kind of a problem. And so different treatments that are out there that parents may encounter. Sometimes people market special whistles where they blow into whistles. The idea is breath support. They might have them do chew toys. Like I've seen clinicians have the children chew on a hard rubber toy. You're looking at me like you're puzzled. These things happen, and then sometimes they might take it looks like an electric toothbrusher. They'll go in and they'll kind of stimulate the mouth, saying all these things. And those things just aren't, there's not any evidence those are effective. So I don't recommend that at all. I know this is going to sound silly, but the best way to teach talking is to teach talking. And the best way to teach speech, even in apraxia, is speech. Now, the thing about if it's really apraxia, there's some probability, low probability, thankfully, but there's some probability they'll never be able to use speech for communication. And so we might actually have to use an augmentative device, which is we might get an iPad, or there's actually computer devices that you can use that are going to talk for the child. And so particularly when the child gets to be 3, 4 years old and you can't understand them, oftentimes we'll recommend that they be taught how to use an augmentative system. The reason is that if you get to be 3 or 4 or 5 and you can't make yourself understood, it's really frustrating. We want to give them that ability to communicate. I do want to say that parents often ask me, well, if I teach them an augmentative system, will that mean that they quit learning how to talk? We're not abandoning speech at all. In fact, there's a whole set of studies that show that when you introduce augmentative, oral speech development actually improves. And the reason for that is that when the parent knows the intended message, they're going to say it back to them. And that's actually the best treatment we have for speech in preschoolers and toddlers.
It's complementary.
It's complementary, right? It's natural, it's complementary. And so we want to use that. So if someone recommends augmentative, I don't want you to push the panic button and say, oh, they're telling me my child will never speak. That's just not it at all. We're using the augmentative as a bridge to communication. Having said that, there are a few, only a handful in my work over many years, but there are a few that never learn to talk. Thankfully, it's rare, but it does happen.
So early intervention is something we hear a lot.
Mm-hmm.
I don't know if it's safe to say it's a buzzword, right?
Sure,
so
yeah.
with the child with apraxia, is there like a window you miss if you don't do early intervention?
No, not at all. In fact, so basically every 2-year-old has speech disorder, and it's because they have an immature motor system. There's the nerves aren't firing as quickly. They don't have this substance called myelin fully developed, which is basically a fatty sheath around the neurons that speeds up the transmission. If you look at the oral architecture, you do an imaging, from the side, you'll notice that, for example, the soft palate goes lower, the tongue's further back. So a 2-year-old anatomically can't make the speech sounds the same way an adult can. So there's motor and anatomical reasons why they all have a speech disorder. But because all 2-year-olds talk that way, we don't worry about it. An example I like to tell parents about that makes sense is you would never expect a 6-month-old to walk, okay? So why don't we have a national program and early intervention to make 6-month-olds walk? Because motorically and anatomically, they're not ready to walk. When you watch them, like you go around and you watch we call them toddlers for a reason. Toddle means,
out.
Yeah, exactly. And so, the point is that what we're looking for in all speech disorder, but particularly in apraxia, is a real deviation from the normal developmental course of speech development.
So how important is it to start those interventions at that age appropriateness?
What I'm going to say is that we have a lot of studies to show that general enrichment is effective, and you can go on the laytalker.org website and get some of the lessons that are there. And they'll talk to you about how you can interact with your child and play with your child in a way that's going to support and accelerate their speech and language development. You always want to do that. But I have had clinicians, unfortunately I've heard this from clinicians where they say, if you don't do X treatment by the time they're 3, we've missed this window, this critical period. It just doesn't work that way. And that's not really accurate in how it all works. And there's lots of reasons for that. I wrote a chapter on it in The Intuitive Parent, not to market my book, but marketing my book. People may want to go and look at that because the idea of a critical period is often misused and overemphasized in some ways. And it's not helpful, and it can lead to panic in the parents. It's unnecessary.
Where should parents start? If their child has apraxia, where should they go for treatment?
So again, we want to have a good differential diagnosis. And again, most speech disorders are not apraxia. So, and we have different treatments. I mean, it's like any other condition. You want to make sure you have an accurate diagnosis. In fact, you would not do the kind of drill and prompting for, say, a school-age child who's learning to make R's and L's and is ready to learn that, who has a mild, kind of developmental speech disorder. You would use a different treatment for apraxia because that kind of on-demand production, just they aren't very good at it. But anyway, if you're having trouble understanding your 2-year-old, your 2-year-old doesn't have words, and you're listening to their babbling, and they're not doing babbling that sounds like words, like ba, ga, da, da, things like that, I would recommend that they talk to their pediatrician about that and get the process started. Again, you do have to be an educated navigator of the system. If they can't do that, it doesn't mean it's apraxia. It may just be a developmental speech disorder. It may be that they're just on late talking generally. It may be that they're just a little bit behind in terms of their speech development. That happens a lot where children make these rapid gains. So you don't want to assume that. If a child's not using words and they're not using a variety of sounds in their vocalizations, and that's something you want to pay attention to. Excuse me. The clinicians that know about this are speech pathologists. So speech pathology is really, the S and SLP is speech, and they really know about speech development. Having said that, I have seen speech pathologists, for example, they'll take a 2-year-old or 3-year-old, they'll drill them like you would, say, a 6 or 7-year-old, and I don't recommend that. You want to use developmentally appropriate interventions for the children. No matter what your approach is, you want to make sure you're matching the intervention with the child's developmental level, and that's important. And toddlers and preschoolers learn through play and through that kind of interaction.
Hands-on.
So you don't want to be, putting them in a school situation where you're drilling them. I have seen people do that. A lot of the children really get upset with that. I did want to segue a bit. One of my colleagues, who is really one of the gurus on apraxia, published a study showing that the incidence of apraxia in autism is much lower than in other children. And the reason I say that is there's whole treatment packages for apraxia and autism, and I've heard people say, and I've seen some things online where they say, apraxia is really common in autism, and it's basically a kind of an entree into these kind of treatments I've told you that are controversial. And so according to one of our world's best experts on apraxia is less common in autism, so I just want to throw that out there. And then people do these motor patterning things that just don't make any sense. Another group that has a high incidence of apraxia are people with Down syndrome. That's important to know because a lot of clinicians will do drill with Down syndrome, and you want to make sure that you're meeting the child with Down syndrome where they are developmentally. And so you just want to make sure you're getting, it's like everything else, you want to make sure you're getting an accurate diagnosis and somebody who understands all the different aspects of development so they're appropriately supporting your child.
Whatever the treatments that you decide to do with your child, how often should you be going, and how involved should the parents be? Should they be doing lessons at home?
So I'm ashamed to say that we don't have good dose studies. And so we don't know how often that people should get treatment. And what we do, practically speaking, is normally there'll be kind of a standard dose of a couple of sessions, in-person sessions a week, and insurance might reimburse that or whatever. And then if the child doesn't make progress, we can then get additional sessions. But it's almost like they have to fail to improve before we can actually provide more support. And so that's kind of a controversial and difficult area. So the culture is, 1 or 2 sessions, for an hour or 2 a week is what people give. Parents should always be included, because if you think about what I just said about natural learning in toddlers and even preschoolers and even school-age kids, there's so many learning opportunities that they have with the parents. Parents should always be involved, because every time the child touches something, every time the child initiates and vocalizes, that's a learning opportunity, and we want to harness that because these children need a lot of support.
So it doesn't have to look like sitting down, okay, here we go, we're doing treatment at home. It could just be every interaction.
So what we recommend as a starting point is, and again, this isn't database, this is just clinical experience, which has a value, but it doesn't reach the level of journal level publication evidence. But we recommend that, we know parents are very busy, and we don't want parents to stress out and feel like they have to do something 24/7. And again, when their child has a severe speech disorder, it's really scary. But what we say is, in the morning for about 30 minutes and in the evening about 30 minutes. And if there's 2 parents, then one parent can take the morning, one can take the evening. But in that, you just completely focus on your child. You play with them as you naturally would. But your goal is to, when the child touches a toy or they vocalize, to make a guess about what they're intending and say that to them, just that word. So the example I like to use is a little toddler toddles up. This would be a typical toddler. They point to the refrigerator and they say, "Wadu." You have no idea what "Wadu" means. They have a meltdown because they're in a terrible twos, and almost all 2-year-olds have tantrums. And then after you kind of figure it out, you realize they wanted some juice. And so when they do that, they go, well, I'll do the next time, you're going to say, oh, want juice, you want juice. And that's exactly what you should be doing. Now, it's normal and natural to talk to them in long sentences, and I want you to do that. But to start off with, when you're doing it and they're having this speech problem, then you just want to say 1 or 2 words, guessing what they were intending, pause a second or two, and then you can add whatever you want. And that's going to help. We have lots of studies to show that really accelerates speech production.
You were talking a little bit earlier, and I want to circle back because it has to do with my next question, is that if you're working on speech, work on speech.
Right.
But with apraxia, if there's a neurological issue going on, right, preventing them. So are there any, you were talking lip, tongue exercises, right. but is there a benefit to that? To like, let's say, to strengthen the tongue in order for them to be able to help make those sounds, right?
Right. So one of my colleagues, motor specialist named Chris Moore, he actually reviewed the strength needed to make speech sounds, and it's super low. And so speech production, unless there's like a neurological condition like ALS or Parkinson's where the strength is declining, it's not an issue. And so this whole idea that you do strength and exercise to improve speech is completely misguided from a basic scientific standpoint. It sounds good. The example I like to use is
it sounds great.
It does. No, it's very logical. It has what we call face validity, but that's not real validity. It's common sense, right? In this case, common sense is doing exercises doesn't work. Anyway, the parallel I like to do is I like to play basketball. I'm no good, but I like to play basketball. Let's say that I wanted to be a better basketball player. Someone might say, oh, you know what? You need to go and do jumping jacks. You need to go and do push-ups. You need to go and probably should do yoga just because I need to be more flexible anyway. But if I did that, it wouldn't teach me how to shoot a basketball. It wouldn't. So those are specialized. Specialized. And so, if I want to be a better basketball player, certainly it's things like shooting free throws, practicing shooting, getting some muscle memory for that activity, absolutely. But you want to do the real activity. And so if you want to teach speech, you want to practice speech and doing these other things, blowing in whistles, rubbing a child's face, I've heard of people putting hot and cold like ice. I've heard of people putting like little shapes on the child's tongue, and they have to say if it's a square or a triangle, all these kind of things. They don't really affect speech. And so, there's a whole line of products and so on that people recommend, but they just aren't effective.
I guess let's just let you say that, right? Using the example for basketball. But if you're doing push-ups, you're stronger to push the ball, right? So
yes, okay, but as long as you're strong enough to push the basketball, then doing push-ups won't affect it. In other words, if I don't have enough strength, but also let's say I want to build more strength to be able to shoot a basketball, it's better for me to shoot a basketball because that's a specific motor activity and the motor group that you would do.
So relating that to speech, it's just better to practice the speech.
Yeah,
do
the speech, and then there's kind of 2 different levels. You can do individual speech sounds, which again, I really don't recommend a lot of that direct drill on how to make speech sounds in preschoolers and toddlers. School-age kids, let's say they're saying a W for an R. You can teach them how to put their tongue up to make an R, and you can practice. They're motivated. I don't ever want it. Another thing is you never want to have. You don't want to make the child upset. If they're resisting the treatment, do something else. Because there's lots of different things you can do. But with a little toddler, it's word production. So they touch a ball and they say ah. You say ball. It's a ball. That's how you do it. And so you're modeling that for them, and that's actually a very effective treatment, and that's very naturalistic. And you do that at home. And then you can work with the speech path to do that kind of thing. And they can help you because speech paths know all the developmental sequences for sounds. Like we know, for example, that B sounds come in early, SH sounds, TH sounds are very late. We know all that. And we can program the treatment around when the sounds are going to come in. We can load up the environment with words. Like one of our little SH studies, we had shiny shark, one of the kids said a bad word that starts with SH. We didn't want to reward that. But anyway, the point is that you can bias it into having opportunities for them to say that. But mainly when they touch a toy or they speak and they initiate, that's the teachable moment you want to harness.
For apraxia, should you be practicing syllables, words, phrases?
Yeah, so the answer is, we want to be as close to the actual final performance like in basketball. So we want to be as close to words as we can be. But certainly there's a lot of interventions, a lot of studies to show that if you do sounds, syllables, and so on, the normal sequence that we teach our students is you get individual sound production, then you go to syllables, then you go to words, then you go to sentences. And that's really how a lot of people do it. That's fine as long as you're not, again, traumatizing the child and pushing them to do something they can't do. And again, remember in apraxia, if you're saying, say this, say that, say the other, you're actually, that's the worst performance condition for them. So you want to think about that. Work. Right, exactly. Yeah.
So some parents listening right now may be told that their child needs a form of treatment called DTTC.
Yes.
Which is short for dynamic, temporal, and tactile cueing. So what does that mean?
Yeah, so there's a lot of versions of that. And so, for example, like when I'm teaching a school-age child how to make an R sound, I might actually show them, in their mouth. I might actually give them some kind of a cue of where their tongue should go. And that's really what that's based on, And so the idea is that it's a speech-related intervention, but you're also, doing these tactile cues, and I don't want to be completely negative. There's elements in it that I really like, but a lot of it I think are really maybe too far away from actual speech production. And again, I worry about that in apraxia because, if you're like doing things that aren't directly related to speech and you're putting a lot of pressure on them, then it might not be effective. Having said that, I think it's fine as long as you're using the effective elements. So you want to work with your clinician and have them tell you what they're doing and why, and have a conversation with them about what they are trying to teach the child and how they expect it to work. And again, I'll be honest, when people use those things, I don't know necessarily what they're doing unless I watch them. Because people will say like I'm doing, DTTC or I'm doing, E.D. Strand's approach or whatever it is. And when I watch them, they're using some elements, but maybe not others. So you just want to know individually what they're doing.
With no matter what you're working on, how do you know if it's effective?
So that's something that, the clinician should always be keeping data and progress. I mean, one of the best things that a speech path can do is kind of be the parent's, coach and partner in helping their child develop. And so there should be like at least monthly like sound inventories where you're seeing if it's how they're progressing. I will also say that one of the sound groups that's affected in apraxia are vowel sounds. And those are very early emerging, and so you definitely want to chart vowel sounds, and they're the things that contribute most to intelligibility. A lot of people really focus on consonants, and that can be appropriate, but if they're having trouble with vowels, you want to focus on that as well. But anyway, there's lots of different measures you can use in terms of prosody, intonation. You can do intelligibility ratings with, like, say, another parent or with a teacher. I mean, you want to chart their progress, and if they're not making at least incremental progress, you want to change it up in terms of how you're treating them and what your support is. So you always want to be collecting evidence of whether your treatment's effective or not. That's how you fine tune it, and that's important. We do that all the time. You have to do that.
This has been great information. If you've got questions for Steve, this is your chance, right? Go ahead and submit those questions because next week we're going to help answer those, right? We're going to read those questions and Steve is going to answer them. So please direct them towards him. Go onto the website. The YouTube channel has a section where you can put those comments, those questions below. Subscribe so you don't miss a thing. Hit the bell. And of course, you can always get great information from the Late Talkers Foundation website.
And remember, the best thing for your child is you.